All right, so now we finished the simulation scenario, and we're going to go into our debriefing. I want to thank you all for your active engagement during the scenario, and we are going to facilitate this debriefing by moving through a series of stages. I'll tell you when we're moving from one stage to the next, and kind of give you an idea of what to expect during that stage. So I want to remind you that we want to remain respectfully and professionally engaged during the debriefing. And I don't expect to hear any kind of offensive or accusative comments. We're not going to do anything that would hurt somebody's feelings, any humiliation, anything like that, criticisms or blame. This is a learning environment, a safe learning environment for all of us. And so this will take us about 30 minutes, or roughly twice as long as we spent in simulation time. Okay, so let's start with the first phase, our reactions phase, and I want to know how you feel about the scenario you just completed.
At first I felt a little nervous, but I think just going over some things earlier prior to the sim kind of helped me, but I was a little nervous starting since I had never taken care of anyone with a spinal cord injury.
Okay.
Same here. I think being our first patient with spinal cord injury, and also just recently learning about spinal cord injury,
right.
I was a bit nervous, but I appreciate being able to go over the content before the simulation and then jumping right into the simulation to go ahead and apply all those skills.
So you're saying the pre-work really helped
and
raise your confidence when you started.
Right, and was able to I was able to familiarize myself with all the information.
That's great, good to hear that. And so let's move into our analysis phase, where we're going to look at a few things that happened during the scenario a little more closely, and allow for time for you to ask me questions if you have questions. Before we do that, I do want to revisit our scenario objectives. So let me just remind you, the scenario objectives for this scenario was included demonstrate proper nursing care and use of spinal precautions for a patient with suspected spinal cord injury, recognize and appropriately manage a patient with neurogenic shock, and use therapeutic communication with a patient experiencing a suspected spinal cord injury. Okay, so now we're all refamiliarized with our scenario objectives. The first thing I want to ask you is to just kind of give me a recap of what happened to this patient today.
Well, what we got in report was from the situation that this gentleman came in through the emergency room. He was tubing with his friends, and he fell out and hit rocks, and his friends got him out of the river and put him in the back of their pickup truck and brought him into the emergency department. That's pretty much his situation. Background wise, I don't think he has any allergies to anything. In our assessment, we went in to assess him based on the fact that he had the potential of having a spinal cord injury. We don't know how severe it is, so first thing we wanted to do when we came in, we did our patient identifiers. We phoned in, we introduced ourselves. We started with the Glasgow Coma scale, the eye opening, assessing his eye, his verbal, to see if he knew where he was he alert nor his. We did that patient identifiers, and then we did the motor stimuli on the Glasgow Coma scale and got a number for that.
Great. I like how you were using that S bar to tell me what happened in the scenario too. That was a great job. Anything you want to add?
Yeah, kind of like Bobby said, and we just wanted to really jump in and be able to go ahead and communicate effectively amongst ourselves, but also with the provider, just to go ahead and get an update, so the provider could get an update on this patient with the suspected spinal cord injury.
Great. And you mentioned, both of you mentioned a suspected spinal cord injury. Ashton, I want to ask you, what was the patient doing or saying that led you to believe there was a spinal cord injury?
Right. Well, he he was on the backboard, and so that was kind of clue one, and he had decreased sensation in his lower extremities, and also said he had hit some rocks when he fell, and kind of couldn't remember the actual event itself until we started asking him questions, and so that kind of we thought it was a suspected spinal cord injury.
Yeah, plus he kept telling us, he kept yelling out, I can't feel my legs,
Right.
I can't feel my legs,
Right.
so,
Okay.
that was one other clue that he was giving us when he was saying he couldn't feel his legs.
Right,
Yeah.
right, good observations. So the next thing I wanna talk to you about is, the medication that was ordered the second time you called the physician. He ordered, dopamine to be given as a drip, and you calculated the drip rate, and, so you decided to hang this bag of dopamine as a secondary infusion, and connected it to his primary IV fluids that were already infusing. So I want to know what thought processes were occurring when you made the decision on how to administer this dopamine.
I don't know what really I was thinking with that. I thought the dopamine could be piggybacked into the saline, but I don't think that was a very good idea because maybe it was diluting the saline was being diluted. The dopamine was being diluted by the saline, and maybe he wasn't getting the full potential of the medication. So I guess what I should have done was maybe hung the dopamine on separate tubing and on a separate channel instead of connected to the saline.
Right.
Okay, and I like how you just used critical thinking to revisit the decision you made, and you in effect changed your clinical judgment of how that should have been done. Now, Ashton, I have a question for you about how the dopamine was hung during the scenario. I noticed that the dopamine bag remained lower than the primary infusion.
Right.
And so what do you know about hanging secondary bags that you can relate to how this was done during the scenario?
Right. Well, it should have been hung higher, or we could have just, like Bobby said, put it on another channel and started another IV for the patient, because at the time he needed his dopamine fairly quickly, and so.
And why did he need dopamine?
Because his vitals and his stats were going down, and hence why we called the doctor and gave him a reassessment and update on his vitals, and asked for that dopamine.
Okay.
And so we needed to go ahead and get that dopamine in the patient fast, so his vitals could come back up, blood pressure, heart rate. And so if we would have started it on a new IV or created a new IV site, so it wasn't diluted by the normal saline, then he would have got it quicker than what he did.
Okay. And the way it was hung, with the dopamine lower than the primary infusion, did he receive his dopamine?
No, he wasn't getting that.
Right, exactly. So, the goal of our medication, the goal of using this medication was to facilitate a better patient outcome.
Right.
But I like how you're now thinking about the mechanics you used, how you decided to administer that medication, and you're realizing there probably was a better way to do that.
Right.
That's great. And I like the way that you've reasoned through that. Is there anything that happened during the scenario that you have questions for me, or that you would like to discuss with your team?
Someone that's like on a backboard, and we're listening to them, we're assessing their lungs and their heart assessment. Do we just not assess their posterior lungs or their back to see if there's like any cuts or lacerations or abrasions on the lower back because they're on a backboard? So how do we assess the posterior part of the patient?
And what do you think about that, Ashton? What kept you from taking him off the backboard?
The fact that he did fall and was saying he couldn't feel his legs and had that decreased sensitivity, and so didn't want to move him at all, just so there wasn't any further damage.
Okay, so that's a lower priority.
Right, and I mean, communicating that with the doctor, but also I did wanna also ask the question in terms of pain meds, you know, we were asking that, but the doctor was delaying them, and so, was that more so because he needed to be seen by a neurosurgeon first, or what was that for?
What do you think about that, Bobby? Why could we not just go ahead and give him some morphine for his pain? Because he was in a lot of excruciating pain when he got there.
Well, I think if we go ahead and give him something for pain, that's probably gonna mask what's really going on with him, and so when the doctor comes, the doctor's not gonna get a true assessment of what his pain is.
Right. And what's our primary body system that we're focused on with this patient?
It's neurological system.
Yes, and so what do we know about pain medicines? They can affect the neurological system and cause you to not be able to determine exactly your patient's neurological state. And in his case, with his condition, his injury, we need to let that neurosurgeon come in here and get the information he needs before we consider changing his neurological situation.
Okay.
Yeah. And I liked how you said listening to posterior breath sounds and examining the back becomes a lower priority. Because what would happen, Ashton, if you just took him off the backboard and flipped him over? What could happen?
We can make further damage or.
Exactly. Great use of critical thinking. All right, so let's move on to our summary phase of our debrief. And I would like to ask you, if you go back to the clinical in the hospital next week and you are assigned a spinal cord patient, just like you had today, what learning point will you take from today's simulation and apply that to your live clinical patient next week?
Learning to do a thorough Glasgow Coma scale on a patient, and I'm now able to know how to see the signs and symptoms of a patient in neurogenic shock.
Good.
Same thing. I know I had a hard time and was a bit confused on the Glasgow Coma scale, but just being mindful and remembering and updating my knowledge on that, and then also reassessment. I know we had to reassess the patient quite a few times, and so you know, with this case in particular, reassessing and hearing those crackles was kind of an indication of that fluid overload, and so just being mindful of that when it comes to a patient like this.
Great. So now in conclusion, I'll ask you one more time if you have any questions that we need to address at this point.
No.
Okay. I want to thank you again for participating in the simulation scenario and remaining engaged while we did our debriefing. Everything that we discussed today should remain confidential according to the confidentiality statement you have signed, and our promise to you that this is a safe learning environment. Nothing leaves this room. I want to also remind you not to share what happened today with your peers, because if they haven't come to take care of Mr. Simpson yet, it kind of ruins the experience for them. We want them to have the same opportunities that you had today. And then I also want to tell you that if you do think of some questions after you leave today, you can reach out to me, and I'll take some time and go over any points that need clarification once you leave today. All right, well, thank you, and have a good rest of your day.